إن شاء الله أهلا بكم. نبتدي session. This morning we have a session about surgical oncology. The first speaker will be Professor Mohammed Al-Shinnawi from Egypt, Ain Shams University. He will talk about pearls and perils. It's a nice talk, inshallah.
First of all, I would like to thank Dr. Ahmed Lotfi, Dr. Ahmed Tariq, and the organizing committee for giving me this chance to be talking to you in this prestigious conference. And special thanks to Professor Al-Ghazali for his efforts in giving us this great conference. I'll be talking today about ductal carcinoma in situ of the breast, pearls and perils. We'll be talking about introduction and definition of ductal carcinoma in situ, its incidence, the classification, the imaging, what are the surgical considerations that we need to adapt when we are dealing with ductal carcinoma in situ. Is it really important to have a great management for the axilla and the other treatment options? When we face cases of ductal carcinoma in situ, we have a lot of questions that we need to answer. As regards the types of ductal carcinoma, is it really affect the prognosis? Is it affect the development of breast cancer? What are the standards of care? What if we have risks of under-treatment and over-treatment, and we can really improve our diagnosis through the MRI and sentinel lymph node? Let's have a small look about the ductal carcinoma in situ. It's a proliferation of malignant cells without invasion to basement membrane. However, it's not only one disease. Actually, it's a group of diseases from low grade to high grade and different according to the grade of the nucleus. Looking at the pathobiological events that happen from normal tissue to atypical hyperplasia to ductal carcinoma in situ until invasion, we'll find a lot of changes on the molecular, cellular, and pathological events. It actually happens from this normal to the invasive. But a lot of the changes that occur really happens during ductal carcinoma in situ as regard the oncogene expression, the changes that happen in the cell regulation, and in the overaccumulation of genetic changes. And a lot of the clinical activities or change actually happens during the ductal carcinoma in situ. So it's now classified into ductal carcinoma with the comedo type, which is the high-risk group, and the non-comedo type, which has the papillary, micropapillary, cribriform, and solid types. But is it really a problem now to talk about ductal carcinoma in situ? Looking at in the United States, we'll find that from every 5 new diagnosed breast cancer patients, 1 of them is ductal carcinoma in situ. There are more than 60,000 patients diagnosed every year in the United States. And the age-adjusted incidence increased up to 32.5 per 100,000 women, and that's rose from 2.3. But looking at the incidence, we will find that not all the types of ductal carcinoma were increased. Actually, the more increase was with the comedo necrosis. But looking into in the Middle East and Egypt, we'll find still our proportions are much more less. In the recent publications from the NCI and from Ain Shams University, we'll find our population is only 4% from our breast cancer patients. What about the natural history of the disease? Actually, there are not a lot of trials about leaving just the disease and following up, but in 1985, Page, he left 25 cases untreated with 16 years follow-up. He found that 28% of them developed invasive cancer, and there was 11-fold increase in relative risk to controls. One of the most famous trials that were done on ductal carcinoma in situ were the National Surgery Adjuvant of the Breast and Bowel Project, B17, and the B24, and they were looking at about more than 4,000 patients as regard the METs, and they found it ranged from 2.1% to 0.6%. The breast disease were ranged from 3.3% to 0.8%, with a follow-up from 10 years to 4 years of follow-up for the patients. And all of this because of the screening. The screening programs made us, we can catch those patients early as possible. And still, imaging and mammography is the golden standard for diagnosis of ductal carcinoma of cyto. And this patient is one of our patients, and we can see here the microcalcifications in this patient. But with the great technology of the ultrasound, it now started to have a rule. Here we can see in this group, in group A, the mass lesion or mass lesion with visible microcalcification. Maybe sometimes they can see secant duct or secant duct with visible microcalcification. There was a great study by a Japanese group as regard the ultrasound findings and histological features of ductal carcinoma in situ detected by ultrasound examination alone. And they found that 80% of those were most similar to benign forms. However, most of them were localized and of low grade. What about MRI? Is it have a rule? Yes, but actually it needs a contrast is required with septal resolution to improve the morphological assessment. And a lot of the patients who are high risk and get negative on screening by mammography, we find them positive by MRI. And we can see here in this slide the appearance of the ductal carcinoma in situ. But until now, mammography is the current standard for detection of ductal carcinoma in situ. And MRI, it could help improve the ability to diagnose the high-grade ductal carcinoma in situ. Having a case of ductal carcinoma in situ, we always think, how are we going to proceed with this patient? Are we going to do just excision or radiotherapy? Are we going to do mastectomy? Do we need tamoxifen? One of the most famous prognostic index is the Van Nuys prognostic index, and it depends now on 4 parameters. In the beginning, it was depending on the size, margins, and pathological classification, and now the age is added. Actually, it's from 4 to 12, where if the size is less than 15 millimeter, margins less than 10, with non-high-grade necrosis and age over 60, the patient will be taking a score of 4. On the opposite side, looking at the size more than 4 centimeter, with margins less than 1 millimeter, high-grade with necrosis, and age less than 40, the patient will be having a score of 12. And accordingly, there were some recommendations where they recommended we can do only excision if the score is 4 to 5 or 6, or excision plus radiation with the score 7, 8, or 9, or mastectomy if the score is more than 9. However, there was a study in 2010 where they made some changes in the Van Nuys where they recommended excision for score 7, but if the margins width is more than 3 millimeter. Excision plus radiotherapy if we have a score 7 and have margins less than 3 millimeter, or patients who score 8 and have margins more than or equal to 3 millimeter. Mastectomy is always required for the patients who score 10, 11, or 12, or multicenteric disease. All of these aims is to avoid the changes to invasive carcinoma and the local recurrence. Looking to these recommendations, we start to think, as a surgeons or oncologists, how are we going to proceed with this patient? Okay, complete excision is an option. However, this is in the low-risk lesion, which is very difficult to define. Most of the recommendations is going with complete excision and radiotherapy. The margins has to be negative. It's recommended to be at least 2 to 3 millimeter, although there are some relative contraindications in this case. like to have it in 2 or more quadrants, diffuse or malignant appearing of calcium, or the patient is not a radiotherapy candidate. And still the option of mastectomy with or without immediate reconstruction is in our mind. It's very weird that until now there is no any randomized trials to control the mastectomy in comparison to breast conservative surgery. And that's a good idea or place for research. What about sentinel node? Is it really important to have sentinel node with ductal carcinoma in situ? Especially now that we are in the era of sentinel node, but now we are thinking, do we omit surgical axillary clearance? We have to put in mind that the involvement is less than 1%. However, we have to think if we have high-grade ductal carcinoma or palpable mass, or we are going to do mastectomy, you have to think about sentinel lymph node. However, it's not that recommended in low-risk disease, unless also if you are performing a mastectomy. There are benefits and there are risks. One of the potential benefits that it can identify the patients who would benefit from systemic therapy, chemotherapy, and those who are with invasive duct carcinoma, we will avoid a second operation for those patients. However, still, there are risks of sentinel node as regard infection, lymphedema. We had a very great talk yesterday about lymphedema and the complications that happen with sentinel node, the anaphylaxis, the risks of complete axillary dissection, the costs, and all of these stuff. What about radiotherapy? Still until now, the patient who we can avoid radiotherapy for in ductal carcinoma in situ is very difficult to identify. And all the studies and randomized control studies showed that the radiation actually reduces the rate of local recurrence by about half. One of the most important trials that was done by the Eastern Cooperative Oncology Group, where they recruited 670 patients, and they showed there were 2 arms, grade 1 and grade 2. They were not randomized, non-comedo with size less than 2.5 centimeter, and the second arm was grade 3 comedo with size less than 1 centimeter. And they just did for the patients only wide local excision. By following up those patients, we'll find here on the graph that in the high grade, 15% of those patients developed ipsilateral breast carcinoma, and contralateral was in 4% of the patients. In the low or intermediate grade, there were about 6% of those patients, they had invasive duct carcinoma in the same quadrant, and 4% in the contralateral breast. In response to that, there was a very great study that was done comparing ductal carcinoma in situ treated with breast conserving surgery and adding radiotherapy. The other study was only conserving surgery without radiotherapy, and they found that they decreased the risk of ipsilateral tumor by more than 70% for both low-grade and high-grade ductal carcinoma in situ. Other study was done by the Oxford group, where they were putting the patients for breast conserving surgery plus or minus radiotherapy. Looking at the first graph, that's in comparison to ductal carcinoma in situ, breast conservative surgery with radiotherapy. As regard the overall, the invasive carcinoma or the ductal carcinoma in situ recurrence, we'll find here that only 28% with the breast conservative surgery alone, and only 12% in the breast conservative surgery and radiotherapy group. If you looked only for the recurrence as regard the invasion, we'll find it more with the breast conservative surgery alone, and if we are going to look for the recurrence with the conservative surgery as regard the ductal carcinoma in situ, we'll find it also more in the breast conservative surgery group. From here, we could say that excision alone, it's recommended to have radiotherapy with it. Post-mastectomy is not unnecessary. We have to put in mind that radiotherapy decreases breast recurrence risk by about 50%. Can we omit it? maybe it's controversial and needs a lot of studies. What about tamoxifen? One of the B24, they compared lumpectomy with placebo, lumpectomy radiation, and tamoxifen. Having a look on this study, we'll find that all breast cancer risks were decreased in the tamoxifen group by 9.3%, ipsilateral 7.7% in comparison to 11% in the placebo group. In the contralateral, it was 4.9% in comparison to 0.3% in the tamoxifen group. They concluded that tamoxifen decreases the risk of breast cancer events by 40%. And this was a comparison between the risk of ipsilateral or contralateral breast tumor with ductal carcinoma, those who are treated with excision alone, excision and radiotherapy, excision radiotherapy and tamoxifen, or excision radiotherapy and placebo, and you will find that the patients who were treated with excision radiotherapy and tamoxifen had the least risk for having invasive carcinoma or ipsilateral or contralateral breast cancer.
Dr. Shinnawi, you have 1 minute. Okay, 1 minute
yes,
more.
Sir. So we are concluding. We could say that local therapy, as mastectomy, breast-conserving surgery plus radiotherapy, is the gold standard. We have considered omission if short lifespan. Systemic therapy as regard tamoxifen is prevention intervention. Consider individual risk benefits. The role of other images, especially MRI, has to be established. It's more sensitive than mammography and sonography. However, the extent was overestimated in 50% of involved breast. The impact of MRI needs to be demonstrated. Key questions here: is there a subgroup of patients with the risk of local recurrence that the risk ratio warrants omission of radiation? Maybe, probably, but they are not yet identified. After lumpectomy, do all patients receive maximal treatment to reduce the risk? Radiation, yes, we have to consider it. Tamoxifen, if ER, PR positive, yes. In the end, we could say that the biology of the tumor, the patient status, treatment, patient option, doctor's decision will make your decision. Thank you very much for your attention.
Thank you, Professor Shinnawi, for this interesting subject discussed and cleared by you. And we shift to